I would request Professor Gatrad to come on the stage and give us a talk on babies and vomit. Professor Gatrad, please give it.
Assalamu alaikum to everybody. And Professor Masood, thank you very much for inviting me today. I indirectly knew Professor Masood recently because I was communicating with him about a mutual friend who in fact is a famous cardiologist who was, I think, your boss in fact when you were in Birmingham. So it's lovely to put a name to a face. This is going to be a very short talk. I was only told to spend 20 to 25 minutes and perhaps have questions for about 5 minutes or so. And I feel really humbled by the fact that there are lots of people here who are very, very much more qualified even to talk about this subject. I sort of kept it very simple, probably for the medical students, I suppose. So I apologize if I'm talking to anybody or talking below anybody's knowledge level. So I think really importantly, vomiting is such a common condition in babies, and it's a condition that parents often bring children to you. It may be just simple reflux, or it may be something more sinister than that. And I think when we go around on a ward round, perhaps we could do a ward round, or alternatively, if you like, what I would like to do is perhaps to carry on the theme of how you would deal with a patient, how do you examine a patient that has come in with vomiting, and also or perhaps look at some investigation that you might carry out as first-line investigation. Now, let's talk of a baby roughly about 4 to 6 weeks old, but that's not an uncommon situation. And I think the most important thing perhaps we've got to know in anything we do is whether a baby is being breastfed or bottle-fed. And having seen a lot of cleft patients recently, I was, I suppose, disappointed that a lot of mothers were not actually feeding with breastfeeding, because breastfeeding itself is not only healthy, as you know, but certainly for cleft patients, it's actually a good thing to do because it forms a good airtight situation. Now, I've just given 10 to 12 tips. I might say 10 in some situations or 12 in one or two other slides. Now, the situation is this. I think, like the situation was in the last patient that we had. A baby that, in fact, has some sort of trauma or a difficult delivery, has had hypoxia. It's very possible that such babies may have intracranial problems and lead to vomiting. And even the baby that we talked about a few minutes ago, who was 5 days old, could well have had vomiting. And if vomiting was there as one of the prominent features, that would perhaps even lead to your diagnosis of a metabolic problem. So the earlier the vomiting is, the more likely that it's going to be a possible metabolic problem, even a birth trauma situation. We also got to remember that birth trauma can lead to persistent vomiting, particularly if you've got a subdural hematoma, because that subdural hematoma could in fact be on one side only, and you may perhaps, if you examine the child properly, be able to, and even do head circumferences, be able to realize that the head growth is a little bit more than you would expect. So a baby that's chronically vomiting, and this is a rare condition, I'm just going to give you some tips to, if a child's head was growing, it could be intracranial pressure, obviously, but one can look at subdural as a possibility. We all know that bile stain vomiting itself is a sinister situation, particularly if it's in a newborn baby. Bile stain vomiting in the first few days of life. That could be perhaps due to necrotizing enterocolitis, or indeed it could be as a result of a duodenatresia or some sort of a bowel disorder or blockage. If it's a Down syndrome child with this seems to be more common amongst Down syndrome and bile stain vomiting. And bile stain vomiting at any stage in a child's life, or anybody that is even older than a child, is in fact of horrible significance. We don't see so much of bloody vomits these days, but I dare say you might get some hemorrhagic diseases of the newborn here, particularly at the age of 4 or 5 days, if a child does have, or baby does have, a vomit, that has got a lot of blood in it, then possibly there is a vitamin K deficiency situation. I don't know whether this happens here. Perhaps it might happen in the villages where vitamin K is not given after birth. But certainly in the UK, all babies that are born regularly have vitamin K. You may remember there was some scare of vitamin K and cancer, but that's not, or leukemia even, but that has not been substantiated at all. Positing. Now, this is interesting because it's common. I think we have to assume that every baby that actually is born does have reflux at some point in their lives. Either this must be overt, in other words, you can actually see it as a nuisance value problem, or indeed it might be something that is not seen, but perhaps if one did a constant check on some sort of a radiographic tool, which we don't have and we shouldn't be doing this, you'll be able to see some food or fluid coming up from the gastric contents up the esophagus. And the reason is obviously, as we know, that the gastroesophageal sphincter is not very well formed, and the diaphragm which forms part of this is not very well developed. So this usually gets better by the age of about a year, but one has to ask about this. And the way I look at it is if a child is in fact thriving and is bringing up bits of feeds, then I don't think there's a big problem, particularly if the bowels are all right as well. Things that worry parents most is not so much that the child actually vomits orally, but when a child actually brings its feed through the nose, that's the worry. And I think that parents, most doctors who have dealt with children for a long time would realize that a vomit that comes through the nose is perhaps more worrying to the patients. From our point of view, on examining such patients, it's important to make sure there isn't a posterior cleft, because these babies may later on go on to have speech difficulties. And I've had one or two children that I've seen later on with speech difficulties who've had perhaps some hearing problems as well. Very occasionally you get children who as soon as the mother starts giving a feed, they start arching their back. Now this, I think, is as a result of, shall we say, esophagitis, for want of a better word. The acid juice has given the baby heartburn. That's the best way to explain it. So as soon as the baby starts feeding, it hurts the baby. It's in these situations, I believe, that if you gave something like ranitidine 3 times a day, 1 milligram per kilogram, 3 times a day is the minimum dose you can give, up to 3 milligrams per kilogram per day. So this is a very common situation in babies, and I would think that quite often during the week I must see at least 3 or 4 babies with parents complaining of a child either vomiting or arching its back before it takes its feeds, or alternately crying a lot of the time. And I feel that the crying may be related to the fact that the baby has actually got some sort of gastritis or indeed esophagitis. Now, the other differential diagnosis in this situation should and can obviously be food intolerance, which obviously at this age is going to be milk intolerance. Now, milk intolerance is much more common than is lactose intolerance. Lactose intolerance, I think, is overdiagnosed in the UK and Western countries to a great extent. Sometimes there is a family history of this condition, but more often than not, it turns out to be cow's milk protein. If there is a problem with breastfeeding and changing breast to bottle, and the child actually continues to have diarrhea, for example, then I think possibility of lactose intolerance is there. But a child that perhaps has got blood in the stools, is vomiting, is crying, may not be thriving, yes, I think the possibility of cow's milk protein is always there. The next thing, which if the child was vomiting between the ages of particularly 3 and 5 to 6 weeks, or even 8 weeks, and I think the longer you live, and I've been doing pediatrics for nearly 40 years now, you tend to see situations where the diagnosis and the disease management and process is slightly different. I'll give you an example. I've diagnosed a baby at the age of 5 days who's been vomiting with pyloric stenosis. In that situation, and I'm a very old-fashioned pediatrician, I actually do not use ultrasound for diagnosing pyloric stenosis. I tend to use the old-fashioned test feeding, but I actually have to really prepare myself, and everybody knows I'm going to take a long time over this. I actually cut my nails. I get the baby completely starving, so the baby, when he starts feeding, gets a good feed. I have my my hands very warmed up. So all these things have got to be done to make sure that you have a good experience of examining. Chances are that if you examine the baby, and I could do this later on with a demonstration, should you wish, Professor Masood, but that's an option. There have been situations, particularly when ultrasound first came into being, and diagnosis of this condition, pyloric stenosis, was not a Paka diagnosis, that I used to actually send patients that I clinically thought had pyloric stenosis before operations for them to learn on the ultrasound what ultrasound images of a pyloric stenosis. It's the other way around. So I think, in a sense, if you're pretty well experienced and perhaps slightly cocky, which occasionally I am, I suppose, you can say, right, okay, you guys will learn the radiologist, that is many years ago, from what a pyloric looks like, pyloric stenosis looks like on ultrasound. Now it's the other way around, because a new batch of pediatricians are actually relying a lot on ultrasounds. And about sort of 2 years ago, I had a new pediatrician who wasn't very sure clinically. Ultrasound was iffy, and I was asked to have a look at this child, and I said, yeah, just send it to theatre, it should be there. And it was. So I think your finger is a very important tool, and this is your left index finger. And I think the feel in that is so typical. Once you've felt a few, you know exactly what you're feeling for. In fact, it's interesting, when I came to Pakistan last time and I was flying back, and I took a textbook with me, and I was reading about pyloric stenosis. I don't know how I happened to just come on this page. The person who wrote this, and it could be one of you guys, I don't know, he said it actually feels like the end of the tip of your nose. And that I think is a very reasonable description of this. And I have never seen it in any Western books. So that I think is excellent, and that I've learned from a Pakistani textbook. I spoke to some parents yesterday, spoke to some doctors yesterday, and I was in Kashmir for a couple of days. And I saw a patient there with vomiting, which was great. And and as it happened, I was going to talk to them about vomiting anyway that afternoon. And when we saw this mother, she was advised by her, I think her Mossy, her mother's sister, that because she wasn't putting on much weight, there were no symptoms, but she wasn't putting on much weight, to actually increase the feeds. And the feeds were actually nearly 35 ounces for a baby who was about 4 to 6 weeks, so about 6 weeks old. And the baby was vomiting and had been brought in. And there's no doubt that 20% of my patients are in fact overfed babies. So the first thing to do is to just find out how much they actually feed. And then you can only do this if you know how much of a feed is required. So perhaps one or two of my slides will, I apologize if these are too low for those people who normally deal with newborn children and little babies. But if there are any medical students or very young doctors here, they may well be useful for them. We always must make sure that if a baby comes in with vomiting, I just think that if baby comes in with anything, literally anything, and even if nothing, urine may be infected. I think people who have worked in the US and who've read, and even the UK, and who have read renal books, and who ever worked with a pediatric nephrologist, actually did a lot of work on normal girls, and she found that 2% of girls actually had asymptomatic bacteria. And there's no doubt that urinary infection is a very common cause of vomiting in babies, as indeed is any infection. So it's always worth checking your baby's urine. Now, the interesting thing is, if your baby has been vomiting excessively, perhaps, and the baby is perhaps thought to be dehydrated, and when you examine the fontanelle and you find the fontanelle surprisingly a bit full, then it's possible that you're looking at meningitis. And meningitis can occur, as a lot of you will know, with no fever at all. Meningitis could occur in the initial stages with possible vomiting, and then all the other bits and bobs will come. Neck stiffness, as you well know, a lot of you will know, is actually a very late sign in a newborn baby, or indeed in the first few weeks of life. Generally speaking, I often find that a family history of pyloric stenosis in olden times, 30 years ago or so, I used to find it much more positive in the family. These days, when I see patients with pyloric stenosis, there usually is no family history. Books always say it's the first-born male. And my experience is actually more females than males, because I've made a data in my mind. I've looked at these, because I just wanted to see what my own experience was. And my own experience is it's more females than males in my particular, and they're not all firstborns either. So I don't know how you interpret that bit of information that is actually in the textbooks. Now, generally speaking, if a child is gaining weight, generally speaking, okay, then the vomiting is usually of a nuisance value. Okay, it could either be the fact that the baby is having reflux, or the mother is excessively concerned about this baby. I've actually had a mum who had been seen by another consultant with vomiting, and was asked, and somebody asked, the GP asked me to have a look at this child. And a few years ago, we used to do domiciliary visits, and I don't know whether Professor Masood remembers this. And when I went home, the baby's head was facing me, and the baby's tummy was there, and the mother was actually opened the door and had the baby like that. And I'm sure that the baby had reflux, and the stomach was actually being pushed up and down with the mother pressing on its stomach. So the only thing that baby needed was really the mother not doing that, and he just settled down. One of the ways, and sometimes we get, and I had one, it's an interesting story, and this happens in the UK, I don't know if it happens here. It's interesting, and I'll tell you about this. I had a young mum of about 16, 17, who brought in children, who brought in this particular child on a Friday, and left the child and was prepared, and comes in and says, "Can I take my baby on a Monday?" And the child was fine, and vomiting had settled. There was nothing happening on Saturday. This happened the second time, and there was a time when, we don't do it very much now, but I think the old-fashioned consultants used to go into the wards every weekend, and a lot of the evenings even. And this second time it happened, it was fine. But when it happened the third time, I said, I must talk to this kid, But she's only 17, and I don't know why she's dropping this child with us, because I think she's actually leaving us as babysitters. So we asked her, and I caught hold of her on Monday, and I said, look, her name was Laura. So I said, Laura, there's something not right here, because whenever you come in on a Friday, your baby is vomiting. You leave the baby here, she's putting on weight, but she actually stops vomiting. So either we're doing something at the hospital or nothing at the hospital, and I can tell you we're doing nothing. So why is the baby coming only at weekends and not during? So she started crying. She visited her boyfriend in Blackpool every weekend. So the time that she had to go there, she dropped the baby for us to babysit. So that's what happened. But interestingly, when you talk about single parents, always remember, I don't know whether, and I think it's hidden. Every culture, every religion, every color, there is child protection issue. And babies have come in to me vomiting. was fine last night. Now he started vomiting this morning. And you fill the fontanelle, and the fontanelle is boggy. Okay, boggy meaning it feels full, it doesn't feel right, it feels whitish. And you know that the child's had some sort of a cerebral hemorrhage. So lots of reasons why babies vomit. Now, one of the catches, in fact, and it's very interesting, one of our registrars, I was giving them this sort of a talk, and about 6 months after I had given him a talk, he excitedly rang me up. And he says, you know something, that talk you had given me, I think I've made a diagnosis. I'll give you the story. Baby had come in with vomiting, having lost weight over the previous week or two. And the baby was about 4 to 6 weeks old. And this baby was shocked, and it was a girl, and had ambiguous genitalia. So the baby actually had congenital hyperplasia. So vomiting, diarrhea, shock. In this country, I agree with the doctors that I've been teaching over the last few days that the diagnosis usually is gastroenteritis. That it could just be gastritis or gastroenteritis. And from my point of view, somebody rang me up and said, look, child's vomiting. And I said, is it diarrhea? They say no. Then my anxiety heightens. If they say it's diarrhea and vomiting, yeah, it could be bad, but certainly there's no intestinal obstruction, or hardly unlikely to be an intestinal obstruction. Now, just going through the feeding regimes and I apologize again, how do we know that that mother was overfeeding or underfeeding? Either we give advice to parents of 150 mils per kilogram per day, or we tell them it's 2.5 ounces per pounds per day. Now, most mothers think in pounds and ounces. Do you all agree? Yes? Even in this country? Yeah? Okay, some say yes, some say no. Okay, but having said that, I asked about 20 doctors and nurses here in Pakistan, and not one of them got it right, that there were 16 ounces in a pound. Yeah, if you don't know that basic information of 16 ounces in a pound, you just do not start advising mothers about what to give. Unless you're talking about kilos, it's a different matter, but you can't say 2.5 ounces per pound per day unless you know how many ounces are in a pound. And they also, one thing they did know is that there were 30 mils in an ounce. Okay. This is, I don't know, I perhaps should have, it may be something that you are aware of, but it's something many, many years ago. I'm talking about 35 years ago, that I thought was something that it was my working way. And quite honestly, without showing off, I could have called it the Gatrad rule rather than the 100-day rule. It is something that people do use in the first 3 to 4 months of life. How do babies gain weight? And if they're vomiting, we want to know whether they're putting on weight. And one of the first 2 questions we ask first, what is your name? Well, ask the mother what the name is of the baby. And what is the weight of the baby? Those are the first 2 things we all ask as pediatricians. Once we've got the fact that a certain weight is available, either from the Red Book in the UK or the mother who has got the information. Some mothers don't have the information as to how heavy the baby was. But if the information is there, it is easier to work out how much the baby should roughly be weighing. Now, the babies lose weight, as we most know, particularly the neonatologists, in the first few days of life. And this could be maximum up to 10 ounces. Then they start gaining weight, half an ounce to an ounce. And I say in England, we work on ounce a day. So what I say is take the birth weight of the baby, take away 10 ounces, whatever that comes to. And if we actually look at the example that I've given you down below, which is if the birth weight was 7 pounds 10 ounces, and we remove 10 ounces, that leaves us with 7 pounds. And if the baby then is 80 days old, then we add 80 ounces. And that's what gives you the weight of the baby at 80 days. I think in Pakistan and places of poor resource countries, where most of the babies are from families that have got poor financial backgrounds, I would guess, and this is just a guess, that we work on the premise that it's somewhere between half an ounce to an ounce per day for the first 100 days. So that's my sort of something that roughly I've learned whilst I've been here on the previous visit and also on this visit. As far as weight gains are concerned, I usually say they double their weight, certainly in the Western countries, at around 5 months, treble their birth weight at a year, and quadruple their birth weight at the age of 2 years. After that, this rule of sevens doesn't apply. I just hope that that's been useful for one or two of you. If there are any questions, I'd be happy to answer them. Now let's take that mother who says 6-7 days ago he started vomiting. It's just possible she's changed from breast to buttermilk. And she doesn't realize that the vomiting is a result of that. Coming back to your question, I think, look, as a cardiologist, I learn from you guys, but I agree with you that any sort of liver congestion, be it congestive cardiac failure or whatever, but I would actually go more than what you have suggested now, and I'm sure if you had the mic, you would have carried on saying what you're saying. I would say that any baby who, after the age, and I hope you agree, has just under the xiphisternum, you feel a right ventricular impulse. Soon after birth, you almost always feel it. But as GPs or doctors, you feel it 3 to 4 weeks onwards, then you must know, and xiphisternum is just there, and if you feel a right ventricular impulse there, a few days, 3-4 weeks after birth, then there is probably something not right in the heart. Now, the two signs of cardiac failure will obviously be tachycardia, which could be from respiratory problems as well, but you'll almost always have hepatomegaly as well with it. So once you've got cardiac failure, you have to, almost certainly, unless I get corrected, have to have hepatomegaly and also tachycardia. So once you have that with congestive cardiac failure, almost certainly you will have vomiting with that as well.
Dr. Gatrad, this is the practical problem about the vomiting, the babies. Mothers usually complain that baby cry for feed, they give feed, and after some time they vomit out, and they then again started crying for feed, and a vicious cycle going on.
Yes.
We know that it's because of overfeeding, but the mothers say that just as the baby is going on crying, we have to give the feed. So how to break this?
Well, I think you then need to look at two things really. As I mentioned earlier, have a look into the child's mouth. I think that's very important because the child might actually have a submucous cleft. Yeah, I don't think even I could be actually accused of not doing that. So that's the first thing. And the second thing you have to remember, one of the other causes, which perhaps when people are breastfeeding a lot is not that relevant, but it could be relevant if you are breastfeeding on an empty breast. And mothers don't know that. Child's not thriving. The baby's feeding on an empty breast is taking in a lot of air. And if you take in a lot of air, you get what's known as aerophagy, and aerophagy is swallowing air, and they bring that out as well. So put that into the equation, aerophagy as well. You could do the same thing with a teat that actually is quite small, and the baby's sucking away. If that happens, then the baby will actually, again, draw in a lot of air. Now, you could actually get into a situation of an embarrassment, which happened to me. And as I said to you, as you said, I've been doing this for a long time. We had a similar situation. I went to all the story, blah, blah. And then I said to the mother, I said, really, you need to change the teat. Not having inquired first as to whether she was bottle or breastfeeding. Yeah? So that was very embarrassing. So you can imagine that, and that in those days, fortunately, I was not experienced. I was on my learning curve. So that was a very, very sharp and a learning curve for me. So yeah, I think, I take your point. I think it's important. And you see, the other thing I think, and I don't want to insult people generally, but I think not only in the UK, but more so here, I think, because I teach in both places, the communication skills are very, very poor. if you come with confidence, if you come with trust, if you come with good empathy, yes, I understand what's going on, but practice it rather than, doing a top-down approach, which is what actually, I'm sorry, a lot of the doctors here do, because I actually do a scenario teaching. I say, right, do what you do normally. And then I don't actually respect patients at all. I'm sorry, but I see it more so here than I've seen elsewhere. So the empathy, the communication skills, the trust, the confidence with which you come in, that partly takes you over the problem that you're talking about. But one thing is certain, a lot of the vomiting soon after birth that has started tends to be reflux, and a lot of it will settle down. As the child sits up, will settle down because of the reflux. But just remember, when he starts crawling again, it may well come back, and then it gets better again when he starts walking. So answer to your question is, I don't know fully the answer, but impress your personality on the parents, which may be not easy sometimes, because some parents know more than you, particularly if they bring some smart auntie with them. So I think we just have to deal with the smart auntie as well. And I can tell you honestly, I could easily deal with a smart auntie. I haven't got a problem with that. मासी जी मैं आपको ठीक से समझ रहा हूँ, लेकिन समझे ना? And that's how my conversation is. Any other question?
I think there are no other questions. Give him a big hand. A very nice talk. So thank you very much. And obviously we will listen more from you on the water on this point.
It's a pleasure. Thank you very much for inviting me.